Thank you for visiting the Senate Finance Committee. Today is Wednesday, March 25th. We're going to hear 19 House bills, and we're going to start with one bill that Senator Clarence Lamb is going to present, House Bill, I don't know, Senator Lamb,
11.
After you present, we'll see who's here next.
Great. Thank you, Madam Chair. Here to present House Bill 1172. For the record, Clarence Lamb, Senator District 12, presenting on behalf of the Howard County Senate delegation. So this is a local bill to update some outdated references in the state statute governing the Howard County Economic Development Authority. And it's changing the meeting frequency of our EDA to better align with other jurisdictions and also provide some more time between meetings for them to be able to plan and prepare for meetings as well. So for some reason, those are actually enumerated in statute. This is just to clarify and mostly technical, just to kind of update the language governing our Economic Development Authority. The Senate delegation is meeting and voting tomorrow. And once the Senate delegation meets, we'll be able to provide a letter to the committee indicating local support for this bill. That is the bill.
Do you have any questions for Senator Lamb? Seeing no questions, that ends the hearing.
Thank you.
We do have some other people here. Jamie?
Here you go.
Jamie Sexton, House Bill 684, are you here?
He's just coming in.
Okay, Raleigh, it's fine.
We don't have any House members here yet, so we're not in any hurry.
I apologize, Madam Chair.
No, you're fine. So Jamie Sexton's going to present House Bill 684.
Thank you very much, Madam Chair. For the record, my name is Jamie Sexton, here on behalf of the Maryland Insurance Administration to present House Bill 684. This bill is in an identical posture as Senate Bill 521, which passed out of this committee unanimously. As the committee may remember from the consideration of that bill, this bill seeks to safeguard patient access to care during contract disputes between providers and insurers amid increasing challenges in carrier-provider negotiations in Maryland. Overall, the bill aims to promote stability in the health insurance market while ensuring that patients can navigate changes to their health care providers effectively. To keep things short and sweet, since this bill has its identical posture has already passed out, just want to ask the committee for support for the bill.
Thank you, Jamie. Do we have any questions about the bill that we have already passed? Seeing no questions, that ends the hearing on House Bill 684. I think that Selena Raleigh's here for House Bill 622, maybe? Selena, do you want to come up and do 622 for us?
Sure. And our director, Ms. Robinson, is joining me for questions as well.
Thank you, Ms. Robinson.
All right, hi, everybody. HB 622 is the agency's departmental, so I'm just going to walk through what changes it makes as well as the work that we did in the House to work with industry to make a few amendments. HB 622, as amended, makes several targeted statutory improvements that are technical in nature and enhance workforce flexibility, strengthen some of our compliance tools, and allow the administration to modernize our cannabis agent training. This bill also reflects a collaborative partnership between MCA and industry to amend the bill in a way that aligns with shared goals and supports a balanced, effective regulatory framework. Per current statute, the incoming micro-dispensary licenses will be solely responsible for medical and adult use cannabis retail delivery to consumers around the state as of July 1, 2026. And MCA is only permitted to issue 10 of these licenses. MCA selected 10 applicants in the first adult use licensing round, with 8 applicants having matriculated to conditional licensure. Micro-dispensary licenses are currently statutorily restricted to a maximum of 10 cannabis agents. These are their employees that can touch cannabis. And that means that just 80 badged agents across the state will be available to ensure these businesses' regulatory compliance and day-to-day operations, as well as to meet demand for all medical and adult use cannabis deliveries effective July 1, 2026. So in this past summer, MCA held some listening sessions with micro-dispensaries who shared concerns that this delivery capacity may not meet demand. In sharing these concerns, MCA requested increasing the employment cap for micro-dispensaries from 10 to 20. As Maryland's regulated market continues to mature and microdispensaries grow the delivery market, increasing this cap supports adequate staffing for compliance, improves patient and consumer service capacity, and allows our small businesses to scale responsibly while still maintaining compliance. So as introduced, HB 622 increased the microdispensary employee cap from 10 to 20 employees, which is what is currently in statute. Industry requested that the term employees be replaced with registered cannabis agents to clarify that only badged agents are counted toward the employment cap for microdispensaries. MCA already interprets statute in this manner, so agreed to this change as a clarifying amendment intended to align the language with current regulatory practice. We also engaged in discussions with both standard dispensaries currently providing delivery services and microdispensaries who are preparing to begin delivery operations. And 5 of those 8 microdispensary conditional licensees reported that they expect to be operational by May 1st. So it's plausible that they will not initially have the capacity to fully serve patients who are currently receiving delivery from standard dispensaries. And patients in more rural areas may experience reduced access because businesses with limited delivery staff are more likely to concentrate their services in more densely populated areas. So the MCA worked with the House to amend HB 622 to extend the current delivery sunset from July 1, 2026 to July 1, 2027. And this would allow standard dispensaries and registrants currently engaged in delivery operations to continue delivering to medical patients until July 1, 2027. To close some of those patient access gaps. HB 622 also modernizes the responsible vendor training program by renaming it the Cannabis Agent Training Program and allowing MCA to tailor the training requirements by license type. So the purpose of RVT, this training program, is to ensure all cannabis workers are trained on critical aspects of their job, as well as Maryland laws and regulations impacting their work. And but the majority of the required course components that are currently delineated in statute pertain to specifically point of sale requirements that aren't relevant to grower and processor employees. And this imposes an undue burden on cannabis growers and processors who employees have to pay for and complete the RVT course despite its irrelevance to their license type. Further, as currently codified, the MCA is unable to dictate critical annual workplace safety or production control training for grower and processor employees specifically. So should HB 622 pass as amended, MCA will adopt regulations establishing mandatory training components that approved cannabis agent training providers must include in the curriculum to ensure that their training is effective, relevant, and adaptable. Please refer to our written testimony for an overview of what those license-specific requirements MCA intends to implement through regulations are. Additionally, in the House, industry did request that this annual training requirement be extended, and MCA agreed to extend the training requirement from annually to at least once every 2 years. So yeah, HB 622 represents a practical and forward-looking improvement to our cannabis regulatory framework. We thank the committee for its time and respectfully request a favorable report. I'm available for any questions.
Thank you. Ms. Robinson, do you have anything you want to add, or just here for questions and support?
Yes, that's
Thank
right,
you.
Madam Chair.
So this was your first session. How's this been for you?
A learning curve, Madam Chair.
Thank you. I do have some questions, just from some questions that were submitted from constituents. When someone's hired, how much time do they have to get the training?
Previously, we have not had a time restriction. They've had the entire year after being hired to do that training. We've promulgated in regulations that training be completed in 90 days.
Okay, so that's in regulation already?
Yes, as of now.
Okay, and then they have to renew it within 2 years, within a certain period of time. And then I'm a little confused about the different licenses for training. So RVT now is retail training, right? What are the new licenses for processors or growers?
The training currently in statute, or as we anticipated in 622?
As you anticipate the changes?
As we anticipate these changes, every badged agent would still have to do training. We would require and allow them to complete this training based on the classification of their license type. So if you are a grower, you could elect to take a training that is tailored towards growing. If you're a processor, you can take training towards processing. The way that it currently is, the content of these courses don't necessarily pertain to what your job is.
So you're changing that in regulation.
Yes, please.
So for the people that already have an RVT license for training, will they be allowed to do the grower and processor training?
Absolutely, Madam Chair. Anyone who is a current vendor or would like to become a vendor in this program would create and tailor content that MCA would review. That content could be focused on dispensary operations or grower operations or processing operations.
So they would create new content and then it would come to you for review. So, you know, one of the complaints we've heard is it takes a long time for that content to be approved. Do you have any time frame that you think it would, I mean, if they're already RVT approved, do you have some idea of how long it would take to get new content approved?
Yes, Madam Chair. We anticipate a shorter timeline for existing vendors. A lot of the approval process for new vendors includes background checks, corporate checks, making sure there's no sort of conflict of interest. But given that we currently have between 7 and 8 existing vendors, we would see this as an upgrade to their existing offerings, and that would be an expedited review.
Expedited? Any time frame on that expedited?
To be honest, Madam Chair, it depends on how many we receive and what staff looks like. Currently, we have about 2 staff members on the team who focus on this, and applications are reviewed in the order that they're received. We are letting applicants know of where they stand in that queue so that they may better prepare if they're number 5 or number 3, and hope to provide a time frame there.
And so if you're already an approved vendor, would you be expedited by being in front of people that are coming in as brand new vendors? I mean, you already have an RVT, right? And then other people put in for training to be train a grower or processor. Would they jump ahead of the current RVT, or would you do the RVT trainings first?
I think we try to do it simultaneously. It depends upon what our human capital resources look like. We do not have a fiscal note attached to this, and so we do not have additional staff coming to support. But we would weigh factors like the ease of the additional review. You know, how many teams need to look at it? The broader and the larger the course, the more hands it needs to touch. And so we have some courses, for example, that are at 4 hours. Those courses were going to take the longest to pass through the process because they just touch more hands. And so we'll consider all of that when we issue these approvals. But the goal is to move expeditiously to get this training up and running as soon as possible.
I'm just thinking you only have 2 staff members, and you have like 7 or 8 current RVTs, and then you could have applications coming in from new people. With only 2 staff members, that's a lot. I mean, it could take a while just because you don't have the staff.
I agree. It could take a lot. Again, we'll be prioritizing and communicating. I think the key here would be to let the vendors know what the timeline looks like, what their expectations may be, so that they can better plan.
Okay. Thank you for those answers. Do I have
Thank
any
you.
other questions for the MCA? I don't see any other questions. Thank you for being here.
Thank you so much, Madam Chair.
Do I have any committee chairs here? I will get some vice chairs. Do I have any committee chairs here to testify? Okay, Delegate Cullison, Vice Chair Cullison, do you want to come up and do your bill?
There's 2. Thank you very much, Madam Chair, members of the committee, Mr. Vice Chair. Happy Maryland Day to all of you. So the first bill that I'm going to speak to you about today is 1112, and that's the study on individual and group health insurance market stability. We established the Health Insurance Protection Committee way back in the 2022 session because we wanted to be prepared for any changes that might be made in the federal committee or at the federal level with regard to support at the state level through Medicaid programs and other systems. It was the entity that gave us improvements in our system, made recommendations, but it's been dormant for a few years. It does exist. Currently, we revitalized it in 2025. Its membership is becoming appointed. I understand that I have been appointed co-chair, and I have every intention of convening this group in late May, and either late May or early June, now that we have everyone, most of the group in place. So this bill that you have, this 1112, is the result of a conversation that was initiated by the then chair of Health and Government Operations with about 30 people, including some delegates and other health experts who have been in the health arena in Maryland for a number of years, both past and present. And that meeting was initiated to discuss the possibility of developing a public option. It was quickly learned in that group that a public option is not valuable or beneficial here in Maryland, so, because of the way our all-payer system works. However, during that meeting, we identified a number of things that we could continue to look at that would respond to some of the changes that we're seeing, especially now after H.R. 1 passage, and make sure that we can maintain our markets as strong as we can. So that's what 1112 does. It expands the charge of the Health Insurance Protection Commission with these particular topics, and it really clarifies and specifies some of the things that the commission should be working on. So with that, these will be the charges that we start with when we convene, and I'd ask for a favorable report on this bill.
Madam Chair, before we go to questions, we have Vinnie DeMarco here also favorable, so if I can bring him up. We're bouncing back and forth between bills that have testimony and bills that won't have testimony. So, Mr. DeMarco, if you want to testify, then we'll see about questions.
Thank you, Madam Chair. Vinnie DeMarco, President of Maryland Healthcare for All Coalition. Thank you, Vice Chair Collison, for putting in this bill. And as you all know very well, Maryland has made tremendous progress in reducing our uninsured rate from 13% to 6%, covering 400,000 people, reducing uncompensated care by over $460 million. And that's been great progress, but that progress is under attack by the Trump administration and Congress, both H.R. 1 and the failure to renew the tax credits at the federal level are really bad attacks. We cannot go backwards. That's why the Health Insurance Coverage Protection Commission is so important. I'm honored that Governor Moore has appointed me to be a public representative on that commission. Look forward to working under co-chair Collison to make this work. This bill is important because it makes clear that there are certain things the commission has to look at, and the one I want to focus on is extension of premium assistance. It's very, very important that Maryland figure out a way to help people who are dramatically hurt by the failure of Congress to expand the tax credits, which help so many people in Maryland and across the country. We're lucky to be in Maryland. The exchange has put together a really terrific backup plan, which helps many of the people, especially lower income people, stay insured through 2026. But that plan doesn't have the resources right now to continue after 2026. So we would love this bill to pass, so to make sure that the commission has, it's one of its priorities, to make sure that premium assistance is there for folks after 2026 so they can keep insured, so we can keep the progress we have made, which is great for the uninsured and great for all of us. And thank you, Chair Vital, for all you've done over the years and your leadership to make all this progress happen. Thank you, you and your committee.
Vinnie, I appreciate your kind comments. Madam Vice Chair, as I'm reading the bill, I'm a little surprised to see part of it is to consider whether to adopt a direct payment system, which I think is fee-for-service. Right. Yeah, or fee-for-service, for all services covered by the Maryland Medical Assistance, which is our managed care. That would be a huge change. Why would we even consider that?
We would, well, it's being done in other states, and at least in Connecticut, and we're looking for ways to make sure that we can use our healthcare dollars in the very best way. So again, it's something the commission will look at, decide if it's feasible or viable, and it could, we would be, at least we want to have the discussion, let me put it that way, around what it would look like if we did something like that. And would we save money? Would we be able to deliver the services the way that it has to be if we were to look at a model like that?
So this is the continuation of a commission that...
It's one that currently exists, and it's a short-term commission. It doesn't have a long-term life.
So
we hope.
If I want to see everything the commission is studying, I need to go back to the prior bill and see that list of items plus these items.
The prior bill, the charge was very broad. It was really to respond to any changes that were made relative to the Affordable Care Act, Medicare payments, the Mental Health Parity Act, really to look at any changes to those aspects of it, but it was very broad. It wasn't as specific as this bill. The things we're looking at in this bill would fit under the things that it was originally charged with in 2025.
Okay, thank you. Do I have any other questions for this panel? Thank you. We're going to do one unfavorable, and then we have a virtual. So the unfavorable is Joseph Nguyen.
Should I move back, Madam Chair?
Usually, yeah. That's why I asked your questions now.
Okay.
Thank you.
Madam Chair, Vice Chair, members of the committee, good afternoon. For the record, my name is Joe Nguyen. I'm the Executive Director of the Maryland MCO Association, here today with concerns about two lines in this bill. The MCOs have been part of the Health Choice Program since its inception nearly 30 years ago, and the MCOs are proud of the work we've done to make the Health Choice Program what it is today. It is what it is today, mostly because of the work your committee and the committee across the street and multiple administrations have actions that have taken over the last nearly 30 years. It pains me to be unfavorable on this bill. I'm really just concerned about those two provisions. We're concerned that it sends the wrong signal at a time when we're undertaking some of the biggest changes in Medicaid's history. Just for context, the MCOs help finance and arrange care for nearly 1.3 million Marylanders in the state. And we're a pretty diverse group. We're made up of hospital-led MCOs, provider-led MCOs, national and local plans. And most of them have been here since the inception of the program. So we're proud of the Health Choice Program. We hope you are too, since this committee and your colleagues across the street and your predecessors helped make it. And if I could be favorable with amendments, I would be just to remove those lines. And my written comments are more extensive, but if anyone has questions, I'm happy to take them. Thank you, Madam Chair.
So, Mr. Nguyen, your comments are, I guess the question that I asked, the amendment that was added, direct payment system or fee-for-service model, was that were your questions? Because there's another line that's kind of interesting. Exploring regulatory exemptions to allow managed care organizations to sell in the individual market without meeting full insurer capital requirements. Are you addressing that at all?
No, ma'am. My members haven't asked about that one, and that's an interesting item, and I just don't have any comments to share on that one from my members.
I appreciate it. Do I have any other questions for Mr. Nguyen? Seeing no questions, thank you for your testimony.
Thanks, ma'am.
We have one virtual favorable, and that's Yvette Delph, I think. Is she? There we go. Hi, Yvette, do you want to unmute and give us your testimony, please?
Certainly, thank you. Chair Beidel and members of the Senate Finance Committee, my name is Yvette Delph, and I'm a retired physician living in Silver Spring, District 19. I respectfully request your support of HB 1112, which would instruct the Health Commission to establish to study the adoption of a direct payment system or fee-for-service model for all Medicaid services. Maryland needs urgent solutions as you consider the difficult choices you are being forced to make in the face of looming federal funding cuts and changes to Medicaid enrollment requirements. A recent report from the Physicians for a National Health Program estimates that based on 2023 expenditures, establishing a fee-for-service model for all Medicaid services would save Maryland up to $521 million every year. According to the Maryland Department of Health, the 9 Medicaid managed care organizations received more than $1 billion in administrative expenses and profits in 2023. That's 13 cents on every dollar they received. Maryland could administer Medicaid directly for 3 cents on the dollar. Since Connecticut implemented such a system in 2012, it has saved $4 billion. The direct payment model would be a win-win-win solution for Medicaid patients, providers, and the state. It would help avoid cuts to Medicaid services, which would be harmful to Marylanders, and minimize increases in the number of residents without health insurance. As in Connecticut, with a direct payment system, we could see less bureaucratic complexity and paperwork, fewer denials of care, and fewer delays in provider payments. At least 7 other states are actively working on similar legislation. I urge you to give favorable consideration to HB 1112. Thank you.
Thank you, Dr. Delph. So I do have a question. In your comments about fee-for-service, you're assuming that the state's going to pay and pay promptly. We have a history most recently of not paying our bills for health care. How do you think providers will feel when they're not getting their reimbursement?
I think that the state, and this is something that the commission should look into, what Connecticut has done. Connecticut has contracted with administrative service organizations, which do not provide care, but help with the administrative aspects, including processing payments. And physicians are very happy with it, and other providers, because there are fewer denials of care, they have less paperwork to do, and payments are prompter. So I think that is something that really the Connecticut model, with its savings of $4 billion in the last 13 years, a smaller state with a lower Medicaid population, I think Maryland really needs to look at very carefully at how it can implement such a system.
Well, thank you for your comments. I handle a lot of issues from providers who are not getting paid in the current Maryland system that's fee-for-service for behavioral health. So that's really where my concern would be. But thank you for your testimony. Do I have any other questions for this witness? I see no other questions. Thank you very much, Dr. Delph. That ends the hearing on House Bill 1112. Madam Vice Chair, do you want to come back and do House Bill 1367? And this is just you. This is the Commission on Reimagining Healthcare in Maryland.
Thank you, Madam Chair, Mr. Vice Chair, and members of the committee. I need notes for this one. This one is something that is near and dear to my heart, and hope that you will see it favorably as I close out my tenure here in Annapolis. I am Bonnie Carlson, representing District 19, and I'm here to talk about establishing the Commission on Reimagining Healthcare in Maryland. This bill is also an outcome of that discussion that we had in October when we began to realize, and as you all know so well, by what you do every 90 days, the beginning is all of the complexities of our healthcare system. Maryland's healthcare system is struggling. It's not because we lack talent or compassion or innovation. It's struggling because it's breaking under its own weight. And far too many Marylanders are paying the price in health, finances, and dignity. This bill proposes the establishment of a commission. This is a long-term commission, contrary to the one we just spoke about. This is something that is forward-thinking and is actually contingent upon getting the funding for it. There's no state funding in this bill. It is going to be completely grant funded, and it's contingent. If that funding isn't secured by July 1 of 27, then the commission is defunct and won't go forward. I promise to work hard on the funding. This body would be tasked with envisioning a comprehensive healthcare system that is patient-centered, integrated across somatic and behavioral disciplines, and capable of evolving alongside needs. As you all know so well, every session you're making decisions about health, the healthcare that's composed of many different components, each operating as though they are independent of each other and not part of a system that is supposed to have a singular focus, the health and well-being of the people they serve. The current framework does not work well enough to meet that goal. The only way to really address those issues is to strategically examine the current framework and identify how the parts should work together and consider options for improvement. There is no determined or predetermined outcome of this commission. This commission's role is it's not simple, but to really comprehensively and strategically look at our current healthcare system in Maryland. It's a long-term approach. You have been sent, I believe, and if not, I will make sure that you get it, a 15-page treatise that was compiled by two of my interns, Nathan Jabat and Marwa Mamandi, which speaks to all of the complications of the way the healthcare framework works now and all of the cited references. But I want to hit on a few top-level things that in this testimony. So let's first look at economics. This is a national problem. The United States spends almost 17% of its gross domestic product on health care. That's equivalent to $12,500 per person per year. Denmark, on the other hand, spends $6,700 per person with better outcomes. In other first world countries, those better outcomes equate to longer lives, fewer preventable deaths, and fewer barriers to care. Higher spending is not the result of higher utilization in the country. It is higher prices and administrative costs. 8% of all premium dollars, healthcare dollars, are going towards administration compared to 1 to 3% in other countries. Those dollars don't reach patients. Now, I know it's a national issue, but we're not here to talk about what's at the national level because we have to be concerned about Maryland. So let's look at Maryland. If Maryland were evaluated as a standalone nation, its per-person spending would rival that of some of the most expensive healthcare countries in the world. The total healthcare expenditures for Maryland, the data that we have, was $69.5 billion in 2020, equating to roughly $11,482 per resident across the population of 6 million people. This is not a lack of investment in healthcare. This is a warning light that we may not be spending these dollars well for people. So what are some of the things that we're struggling with in Maryland? Again, these issues are going to be very familiar to you. We have a historic physician shortage. Currently, we are meeting only 66% of our primary care needs. We are among the lowest states in practitioner density. This deficit is going to increase by over 1,000 physicians in 2030 and 1/3 of our active physicians are now nearing retirement. Costs are rising. Our drug spend in Maryland alone is 20% of our commercial insurance market. The costs rise exponentially. One example, one with which I know you're all familiar, insulin. The cost of insulin increased 1,200%, 1,200% between 1996 and 2017 for no apparent reason except that they could do it, according to the CEO. The median annual cost of the new drugs being developed in 2023 was $400,000 per year. One drug, $400,000 per year, and that's the median cost. While rising drug costs are a significant factor, the overall cost of care is rising. So how does this affect our residents? In 2023, 15%, or 327,000 Marylanders had unaffordable medical debt. In 2026, our bronze plans have an average deductible of $9,200. So if you're buying a bronze plan, you're buying at the lowest premium, but your deductible averages $9,200. It goes up to $19,000 for a family of 4. We're transitioning to the AHEAD model. And under this transition, the Medicare fee-for-service rate setting authority will shift from the Maryland Health Services Cost Review Commission to the Federal Centers for Medicare and Medicaid. This shift creates potential fiscal uncertainty, particularly if the federal support, currently estimated at approximately $1 billion annually, is reduced after 2027 and will have a significant impact on our hospitals' ability to provide service or even to stay open. Our behavioral health needs, again, something you hear about frequently in this committee, are significant and increasing. More than 325,000 Marylanders rely on public behavioral health services, but our workforce shortages and fragmented funding, because of the workforce shortages and the fragmented funding, that demand cannot be met. Rural residents face substantial travel burdens for behavioral health care, often losing work for one appointment. Finally, with respect to our residents in this presentation, the residents on the Eastern Shore have life expectancies 7 years shorter than those of us who live in Montgomery County. We have a responsibility to our residents to provide access to high-quality health care, and we try to do that every year in this committee, in the health committee, in our respective bodies. But we're taking a Band-Aid approach to a massive hemorrhage. It's time for us to take a more systemic approach to meet that responsibility. The establishment of the Commission on Reimagining Healthcare, it's not a luxury now. It is a critical and economic necessity. Here in Maryland, we face mounting pressures from costs, workforce shortages, persistent disparities across access and outcomes. We have a moment in time right now when we are transitioning to the AHEAD model, which speaks to greater community involvement, engagement, and collective working towards a single goal of the health and well-being of our residents. And what we would build is a system, or what we would hope to build through this commission, is to identify what we would need by prioritizing equity, sustainability, and patient-centered care. The passage of 1367, I knew I'd get those numbers right, signals a commitment to thoughtful, evidence-based reform that will help chart the course for the next generation of healthcare in Maryland. I ask for your favorable support of this bill. Thank you very much, Madam Chair.
Thank you. Senator Washington?
Thank you, Madam Chair, and great to see you, Madam Vice Chair. This is a commission, right? Kind of like a work group that has members on it?
Yes.
Is that right?
Yeah.
Will this be a brand-new commission or extending it commission?
No, this is a brand-new commission.
Got it.
I modeled it, this was not a solo effort. We modeled it after the Kerwin Commission. We looked at, who was represented on that, and then we brought in the healthcare equivalents of those folks.
Well, I served on the Kerwin Commission for a long time, so I know what that looks like and feels
Right.
like, so that's great. About how many members, you think?
I think as we've designed it right now, it has about 23, which
23.
is big.
Got it.
Which is, I would ask us to be judicious if we were going to add any additional members.
Or maybe we can take away some members too. Okay, I think it's a great concept, great idea, and so I really appreciate it. Moving some of these commissions or work groups, I think are really important, even in election years. I think it's really important too. So thank you very much.
Thank you, Delegate. Senator. Thank you, Senator.
I used to be one of those.
You did. I remember that.
Thank you, Senator. Senator Guile?
Thank you very much, Madam Chair. Madam Vice Chair, thank you very much for this good bill. So now that you're retiring and have all this time, how would you like to be on the commission?
There is a public representative on the commission.
Noted.
It was not designed for any particular person. But,
Well, thank you.
thank you.
Yeah, and thank you for your many, many, many years of service. We will miss you. So thank you.
Thank you.
Thank you, Madam
Thank
Chair.
you, Senator. Okay, I don't see any other questions. Thank you very much, Madam Vice Chair. And as Senator Guile said, thank you for your service and your work in healthcare for many years. And I see your chairs here, so I'm going to let you run back to committee and have your
Exactly, that's
chair
what's
come
happening.
up next. How's that?
We're playing musical seats. Thank you.
So Chair Bagnall?
We're letting some of our subcommittee chairs sit in the hot seat today.
You're going to present House Bill 1485, Public Health Crisis Response System.
Thank you very much. Good afternoon, Madam Chair, Madam Vice Chair, Mr. Vice Chair, sorry, coming from my committee, Mr. Vice Chair, and members of the Senate Finance Committee. For the record, I'm Delegate Heather Bagnall, District 33C, Anne Arundel County, here in strong support of House Bill 1485, Resources for Family Members in Trauma-Informed Care Training, Tierra's Law. You have my written testimony, so I'll summarize. We talk a lot about how to destigmatize healthcare in this committee and in our partner health committee across the street. Tierra's Law is about turning a tragedy into action to help others. Because this is sponsor only, I want to share a little bit about how we got here and why we need House Bill 1485. And I'll refer you to the preamble because a lot of that is in there. And I'll just highlight a few things. On May 17th, 2020, Tierra Brown, Maryland resident living with sickle cell disease, died following an overdose after developing a dependence on prescription opioids that had been prescribed to manage her chronic pain. And following her death, there was stigma associated with substance use, contributed to the mistreatment of her family and friends, exacerbating their trauma, despite medical circumstances underlying her condition. This series of events highlight the pervasive stigma associated with drug overdose-related deaths and reveals deficiencies in first response practices, information sharing, and survivor support services. And families' encounters with first responders are often highly traumatic because overdose incidences are frequently framed as criminal investigations. Tierra's mother, who is a peer counselor herself, brought this idea to me. She was left alone in her home with her daughter's body while the investigation ensued. Because every overdose death must be investigated by the Office of the Medical Examiner, her home was treated like a crime scene, and she was treated not like a grieving mother, but like an accomplice. The only resource she was provided by emergency services was a receipt for her daughter's body. Friends and family were left wondering what to do and how to heal, with Tierra no longer a person, but a statistic. And as a peer counselor, she shared that her experience was not unique. Now, no Maryland family should experience the gravity of a behavioral health crisis or overdose death, whether at home, in a hospital, or at the medical examiner's office, and be left without a clear pathway to support. And just as importantly, No interaction with our healthcare system or with government employees should compound the trauma they are already carrying. House Bill 1485 is about meeting families in that reality. The bill requires the Maryland Department of Health to develop a standardized, accessible resource pamphlet outlining state and national crisis services, including the 988 Suicide and Crisis Lifeline and other behavioral and mental health supports and programs. In specified circumstances, that information must be provided to family members, whether the point of contact is EMT in a home, hospital personnel, or employees of the medical examiner's office. This ensures consistency across settings. It ensures that wherever a Marylander encounters the system in one of life's most devastating moments, they receive clear direction. The bill also directs the department to review trauma-informed care training for relevant healthcare professionals and report back to the General Assembly. Because emergency response is about more than intervention. It is about how we communicate in the aftermath, the tone we use, the clarity we provide, the recognition that families are absorbing shock, not just information. Maryland has invested in crisis infrastructure with 988 mobile crisis teams and statewide behavioral health services, but resources only matter if they are placed directly into the hands of families in a form they can return to later when the fog begins to lift and the questions finally surface. Families are already traumatized by these deaths. No one should have to retrace their steps days later trying to remember what was said in the worst moment of their lives. We have a responsibility to ensure no healthcare provider and no government employee adds to that trauma through inconsistency, bias, silence, or a lack of direction. Our obligation is not only to act, it is to steady. With House Bill 1485, we will meet this obligation with compassion and humanity. For all these reasons, I respectfully ask for a favorable report on House Bill 1485.
Thank you, Madam Chair. Thank you for your bill. I don't see any questions.
Thank you very much.
Get back to work. Thank you. Next, we're going to have Aaron Hopwood come up to present two of Chair Penny Melnick's bills. Speaker Penny Melnick's bills. So, Aaron, would you like to start with House Bill 1365, the Health Occupations, Public Health and Insurance?
Yes.
Menopause Provider Training Coverage Requirements.
Good afternoon, Chair Beidel, Vice Chair Hayes, and distinguished members of the Senate Finance Committee. My name is Aaron Hopwood. I'm Legislative Director for Speaker Penny Melnick, and today I'm presenting House Bill 1365. Although this bill is not marked as a cross-file, it is, as amended, it is identical to Senate Bill 892, which passed the Senate 41-0. This bill is designed to improve the quality of women's health care by allowing certified or licensed healthcare providers who are required to complete continuing education to receive double credits for continuing education on menopause and menopause-related symptoms. The bill requires the Maryland Department of Health to identify at least one training program that may be used by providers for this purpose, and the bill requires insurance coverage for menopause treatment. The bill also adds the executive director of the Maryland Commission for Women and one expert on menopause to the State Advisory Council on Health and Wellness. Finally, this bill requires the Maryland Commission for Women to evaluate policy initiatives that improve health and economic security of individuals with menopausal conditions and requires MDH to establish an action plan with community health workers to provide access to menopause-related healthcare services and to evaluate methods to increase opportunities for clinical training on menopause.
Thank you, Aaron. John Crom is here too, and I neglected to call him if there's any questions.
Mr. Crom is here for the next bill.
Okay, I had him on both bills, but thank you. That's okay. I don't see any questions, so it's fine. That ends the hearing on House Bill 1365. John, would you like to come up for House Bill 1563, Emergency Room Services and Post-Acute Care Coverage and Facility Studies? And Aaron will present, and you'll be here for questions. Thank you.
Once again, good afternoon, Chair Beidel, Vice Chair Hayes, and members of the Senate Finance Committee. Today I'm here to also present House Bill 1563. As this committee is well aware, Maryland's emergency room wait times are among the longest in the country. In 2024, the General Assembly enacted legislation to establish the Maryland Emergency Department Wait Time Reduction Commission to address factors throughout the healthcare system that contribute to increased emergency department wait times. The commission submitted an annual report in November 2025, and among the report's key findings is the significant impact of post-acute care shortages in both long-term care hospitals and skilled nursing facilities on delay in discharges. The report also found that data fragmentation across acute, post-acute, and community settings hampers system coordination and policy design. Two of the Wait Time Reduction Commission's selected priorities are standardizing bed capacity and occupancy metrics and improving post-acute services. House Bill 1563 addresses the standardization of metrics by requiring the Maryland Healthcare Commission and the HSCRC to conduct a study to quantify the state's bed capacity in post-acute care settings and in hospitals, and make recommendations for a collection and auditing process through which hospital and post-acute beds are reported to MHCC and HSCRC each year. The bill addresses access to post-acute services by requiring MHCC and HSCRC to conduct a study analyzing options to facilitate clinically appropriate transitions from acute to post-acute care settings. In addition, access to post-acute services is addressed in the bill by requiring insurance carriers to include in MIA's annual Appeals and Grievances Summary Report data on adverse decisions related to admissions to skilled nursing facilities and inpatient rehabilitation facilities. Finally, the bill addresses the impact of insurance denials on emergency room utilization by authorizing the insurance commissioner to conduct an examination of any carrier that has issued a pattern of adverse decisions for a claim or authorization request for services in an emergency department, and the bill authorizes the commissioner to have these adverse decisions independently reviewed. House Bill 1563 will complement and inform the work of the Emergency Wait Time Reduction Commission and assist the state in our continued efforts to provide timely health care in the most appropriate setting. House Bill 1563 has no opposition, and the bill passed the House 133-0. On behalf of the Speaker, I urge a favorable report on this bill.
Thank you, Erin. I have a question. I don't know if it's for you or for John, but there's an adverse decisions work group that I know because I'm going to be the chair starting next week. So I wonder how much of this information would be also submitted to the adverse decisions work group, or is there some redundancy here?
I know that the MIA is here. Jamie Sexton is here, if I could defer to her to answer.
Well, I think the MIA is setting up that adverse decisions group, so I don't think they're here now. Okay, we'll have to figure out and touch base. It could just be that you give information to both. Because this has other issues too about post-acute care.
Correct. Yeah. So there could potentially be some overlap depending on where the adverse selections group wants to go, and where you want to go. Thank you for serving as chair. But I think there would not be a problem to coordinate, who's doing the work.
Okay. Yeah. Thank you. Do I have any other questions? I don't see any questions. Thank you very much for your presentation. And that ends the hearing on House Bill 1563.
Thank you.
Let's see. Delegate Kaiser, you are here. Consumer Protection Menstrual Hygiene Projects, House Bill 1357. Hello. How are you?
Yes. Well, thank you. Thank you, Madam Chair. Thank you, everyone. And I'm sorry, you said 1357 because I have the two today. First one.
You can start with either one you like.
I don't remember which one my aide told me to do, and she stepped out for a second, so I'll have to just go with 1357. Thank you. This is in regards to consumer products for menstrual hygiene products. So thank you, Madam Chair and distinguished members of the committee. My pleasure to come before you today, and Mr. Vice Chair as well. Come before you today about this bill I think of as a consumer protection measure to require ingredient transparency for menstrual products sold in Maryland. I'll try not to read my testimony, but I think it's pretty obvious how millions of Marylanders are using these products, using them for their lifetime certain part of their lifetime. But unlike food or cosmetics, they're not required by federal law to list their ingredients, and people just don't know. There's been recent research to suggest that there's potentially some bad items in them, whether it's toxins, PFAS, and so forth. And so while I'm not saying that the research is right or wrong, I'm saying, all right, well, let's have some openness, transparency. Generally a good thing, let's give consumers information. This is happening in some other states, and a question could be asked, do we need to do this if this is happening in other states? And the answer to that is, let's be on the front end of this. Let's use the bully pulpit of the state of Maryland to say that we care and that we're looking at these issues. While it's true that some of the larger states are doing it, that may drive it nationally, but not yet. I wanted to discuss some amendments. We're still ironing out some amendments, and we're really close, and we will be sending it to the committee. We will be sending it to the analysts. We had some original amendments which were enacted in the House that had some changes to definitions. However, due to the speed that the bill moved, the amendments missed some of the industry's concerns, and we have offered them new language, and they are fine with that language, but they can obviously tell you that. Unintentionally, the Office of the Attorney General didn't have a meaningful opportunity to review or comment on the amended version of the bill prior to its advancement. They have two concerns, I believe, one of which we are likely satisfying, but maybe not the other. But I just want to put it out there that we're still working with them on those amendments. And then I'll end with where I maybe should have started. Not only did this bill pass the House with a vote of 132 to 1, and if you served in the House, you know who the one is, but not only did this pass 132 to 1, but in the Health Committee, there was bipartisan co-sponsorship, that pile-on amendment as can happen. So, Madam Chair, thank you. I appreciate a favorable report on House Bill 1357.
Thank you. Are you a vice chair now?
I sure am.
Madam Vice Chair, thank you.
Yes.
I thought that happened. Senator Washington?
Thank you, Madam Chair. Thank you, Madam Vice Chair. Good to see you. I like this bill a lot. I wish I could pile on too. I have been contacted by the OAG's office about the bill and about the amendment, and maybe you can just describe it just a little bit more about their concerns. It's about the Consumer Protection Act and the penalty provisions that were removed from it, and maybe you can explain why that part was removed, to give this committee more understanding of the reasons behind it.
Certainly. I think the enforcement penalty may have been removed by the committee. My original amendment had language about $1,000. The original penalty was $1,000 per box. And I think it wasn't written correctly. So, I think on that piece of it, I agree. I think there's still some, philosophical differences on how we should do enforcement. And we are trying to align things with the other states' bills, and we do things a little differently here in Maryland. So I could follow up with you more on that exact challenge.
Yeah, that'd be great. They also mentioned that part of the bill creates it manufacturers would be able to create their own enforcement mechanisms instead of using the legislators' mechanisms to enforce some of these laws. Can you describe that? They say it says from the Consumer Protection Act and why manufacturers should be able to create their own enforcement mechanism when a legislature has already established one or something into this effect.
I read through that. I may have missed that nuance, so I clearly have to follow up with you, Senator.
No problem.
Thank
Just
you.
wanted
It's good to see you today.
Yeah,
Yes.
of course. Yeah, no problem. Thank you.
Thank you,
Sorry about
Senator.
that.
So it sounds like we're waiting to hear from you with some additional amendments.
Yeah, so we are close to them. My aide has been working with the OAG's office, been working with industry, and we'll be sending you something that I think irons out many, but maybe not all, of the concerns.
Well, we have plenty of time left, Madam Vice Chair. We have 20 days, so not a problem.
I'm so glad to hear you say that.
Thank you. Thank you for your testimony. I don't see any other questions. That ends the hearing on House Bill 1357. Next, you're going to do House Bill 1377. And we have you as the sponsor, and you also have Matthew Hollister, James Hollister for questions.
Yes, and thank you so much, Madam Chair. Again, I'll say Happy Maryland Day. I'll get on the record. And I want to thank you. I had asked if Matthew Hollister could be available for questions, so I think not testifying, but in case there are some technical questions. So let me tell you all about this great bill that Mr. Hollister brought to me about the Prescription Drug Repository Program. And it just expands on the drug repository structure we currently have to include medication collected during Drug Enforcement's National Prescription Drug Take-Back Days. So I think you all can imagine the billions of dollars of medication that gets thrown out every year. People who maybe decide to change medication, someone older who may pass away before they started some new medication. For whatever reason, there's a lot of unopened bottles out there. And when they are, they get thrown away. And given the cost issues, given affordability, given the lack of access, these drug take-back days that we currently have are amazing. And we have them in Maryland. But what also happens is that the federal government does this through the National Prescription Drug Take-Back Day, and it's administered by the DEA. And their stuff just all gets thrown away. They have a different way of doing things. And all we're trying to do here is to create this pilot in a few locations to start to work with those drug take-back days with the DEA so we can allow for some of that. So rather than all of that being trashed, being able to keep some of that. So there was something mentioned in the opposition about the lack of safeguards, but the safeguards that exist as designed in this bill works with current practice. And this would be a pilot. I think this bill's a practical, common sense step toward reducing waste, strengthening medication access, and ensuring that safe, usable prescription reach patients rather than being destroyed. And I just want to say something kind of ironic. During the hearing on the bill, one of my colleagues asked the question of all the other things we're doing this year in the legislature, how is it that we're asking to work with the DEA when we're saying in other places, let's not work with the federal government? And I just want to point out that not only did that member vote for this legislation, he co-sponsored it as well when there was bipartisan co-sponsorship of the bill as it was moved through the committee. So I just add that as a point of humor, Madam Chair, and I thank you all, and glad to take any questions and glad to field the tough ones to Mr. Hollister.
Thank you. Unfortunately, at this point, a lot of our members are over in the House testifying, but do I have any questions for the sponsor or for Mr. Hollister? I don't see any questions. Mr. Hollister, thank you for being here. That ends the hearing on House Bill 1377.
And thank you, Madam Chair. Thank you, Senator Guy.
I think next we're going to go to Delegate Acevero, House Bill 628, Human Services Foster Care Transition Grant Program.
Good afternoon, and thank you, Madam Chair, Vice Chair Hayes, members of the Finance Committee. For the record, Delegate Gabriel Acevero here to present House Bill 628, legislation that simply would establish the Foster Care Transition Grant Program within the Department of Human Services. The bill really recognizes a simple truth that young people aging out of our foster care system deserve support at the very moment they're expected to begin adulthood. And for too many reasons, transition-age youth in our state turning 18, it means that stepping into independence could also be an unknown thing, and it could also be very destabilizing. And so for our foster care youth, adulthood is not necessarily something that folks look forward to, but really dread because of the lack of not just familial, but financial support as well. HB 628 addresses that reality by creating a targeted foster care transition grant program for individuals who were in and out of home placement on their 18th birthday. The bill's been amended in the House, and so what it does now is it takes effect in fiscal year 2028 for eligible youth on their 18th birthday, but also ensures that the monthly grant is for 1 year, and this is to ensure that youth transitioning out of our foster care system is strongly linked to the kind of services that they need, from housing security, employment, as well as long-term care. Maryland Legal Aid, which represents thousands of children and young adults in child in need of assistance and guardianship matters across our state, notes that these challenges are well documented. The National Youth in Transition Database notes that Youth in Transition Database Maryland cohort data shows that about 23 to 27% of Maryland youth transitioning out of foster care reported experiencing homelessness within 2 years of exit. This bill was really inspired by a constituent of mine who had met, who now has a family of his own, but aged out of Maryland's foster care system. And what was of note to me was that he shared that when he aged out of Maryland's foster care system, in addition to not having familial support, he did not have financial support. And so this bill was designed to provide direct cash assistance to those kids aging out of our foster care to ensure that they're able to meet their basic needs, while also knowing that we as a state care about them, we see them, and we're willing to put the necessary money where it needs to go to ensure that our youth, particularly our youth transitioning out of foster care, are taken care of. The bill specifies that payments under the program may not be considered income or resources when determining eligibility for Medicaid, the Maryland Earned Income Tax Credit, or any state or federal financial aid and college support program. House Bill 628 is an investment in prevention, stability, and dignity, and it is also an opportunity for Maryland to ensure that no young person is left behind simply because they aged out of our foster care system. And so for those reasons, I would ask this committee to issue a favorable report, and I thank you for the opportunity to present my bill.
Thank you, Delegate. Senator Hayes.
Thank you, Madam Chair. Thank you, Delegate. This is a smart piece of legislation. Many of the young people, when they transition off to foster care, they either go on the other side of the system and apply for SNAP and medical assistance, or, as you've alluded to, end up homeless. And so we wind up having the state wind up having to pay for them anyway. Do you know, and it's unfortunate that the fiscal notes are so limited in their analysis, do you know if there has been any other information that's available on how much young people who are transitioning from foster care is costing the state?
A very important question, and thank you, Senator and Vice Chair, for it. I will take it as an opportunity to not just, speak to the positives of what this bill would do, but to also highlight a bill from one of our colleagues who will be coming after around a commission or a study group to look at kids aging out of our foster care system in our state. What resources will we need to do, what's working, what's not working. So I will make a plug, because I imagine, to your question, that is information that we would be able to get or to glean from this study or this work group that the good delegate from Howard County, who I'm sure will be presenting in a few, her bill about. But this bill is really in response to what we're hearing from a lot of kids aging out of foster care, is that, look, once I turn 18, the state sees me as an adult. I don't have familial support, but I also don't have financial support to meet my basic needs. And so this is really just the beginning of a response to what we're hearing from our foster youth.
Absolutely. Thank you.
Thank you for the question.
Any other questions for the delegate? Seeing no other questions, that ends the hearing on House Bill 628. Thank you.
Thank you, Madam Chair. Thank you, committee.
House Bill 771, Delegate Miller, Health Occupations, Human Trafficking Awareness.
Good afternoon. Thank you, Madam Chair, Mr. Vice Chair, members of the Finance Committee. For the record, I am Delegate April Miller, representing District 4, Frederick County, and I am here to present House Bill 771, Health Occupations Human Trafficking Awareness Training. This is the first opportunity this committee has had to hear this legislation, as my work with the crossfile ran up against the Senate bill cap. I appreciate your consideration and the time to present House Bill 771 to you. Human trafficking is not a distant problem. It is a Maryland crisis. Because of our location along the I-95 corridor, our state serves as a major hub for both sex and labor trafficking. As you can see here on the map, we are red hot. What kind of victims? Who are the victims of sex trafficking? Anyone can be a victim of sex trafficking. There are certain demographics that are more vulnerable to being exploited through trafficking. The average age of a child sex trafficking victim is 12 to 14 years old. Between 60 and 70% of trafficking victims are from the child welfare system, and girls with a history of sexual abuse are at higher risk of being trafficked. 1 in 7 runaway children are reported as sex trafficking victims, and the average lifespan of a non-rescued trafficking victim is 7 to 10 years from the time they were trafficked. Between 2013 and 2024, over 1,345 child sex trafficking victim cases were reported in Maryland. There's a lot of underreporting. In 2021, while Maryland ranked 13th in signal volume to the National Human Trafficking Hotline, only 16 of those reports came from medical professionals, a staggering missed opportunity for intervention. Research indicates that up to 88% of trafficking survivors seek medical care while actively being exploited. This means healthcare providers are often the only professionals a victim encounters outside the control of their trafficker. The clinical setting offers a rare moment of physical separation between a victim and their exploiter. House Bill 771 provides the training necessary for providers to move beyond treating the symptoms to identifying the person in front of them. Trained professionals are taught to look for indicators of control, for example, a patient who does not have possession of their own ID, or a companion who insists on speaking and interpreting on the patient's behalf. While sex trafficking receives the most attention, 14% of healthcare identified cases involve labor trafficking. And House Bill 771 ensures providers can recognize the signs of forced labor, which are often masked as workplace injuries or chronic neglect. I'd like to share a quick story from the testimony of Hartley House Incorporated, which is based in Frederick County. In Frederick County, a 15-year-old trafficking victim was taken to multiple medical offices over several days. She presented with injuries, a sexually transmitted infection, and an adult guardian who would not allow her to speak or to be examined alone. Staff recognized that something was wrong, but the only action they knew how to take was to call the National Trafficking Hotline. That alert did reach our team 1 month later. By then, she had been taken out of state. She has not resurfaced since. With proper training and clear local protocols, that child could have been kept in the exam room longer, local and law enforcement could have been called, and she could be safe today. House Bill 771 does not create an unfunded mandate. It instead leverages the University of Maryland Safe Center, which they provided testimony as well, to provide the training outlined in this bill at no cost. We are not asking professionals to pay for additional credits. We are simply making life-saving information accessible. And importantly, this training will count as an optional continuing education credit, allowing health professionals to satisfy their existing CE requirements while gaining a skill set that could save a life, integrating seamlessly into their current licensing cycle. The curriculum is designed to ensure providers do not inadvertently re-traumatize victims, which is a significant barrier to survivors seeking future medical care. And the bill does require relevant boards to conduct communication and outreach because we are trying to raise awareness of human trafficking in medical settings and to inform healthcare providers of the opportunity to use this course for continuing ed credit. Maryland would not be alone in this effort. States such as Florida, Texas, Michigan have already implemented similar CE requirements for health professionals, resulting in documented increases in victim identification and stronger multidisciplinary responses to the crime. We worked with local partners and the Maryland Department of Health on this amended version of the legislation, and with their support, House Bill 771 passed out of the House unanimously with some additional co-sponsors. We are ensuring that when a victim walks into a Maryland clinic, they are not just seen, they are recognized, and we are turning our healthcare system into a frontline defense against exploitation. I urge a favorable report on House Bill 771, and I would like to thank all of the organizations that did submit testimony in favor of the bill.
Thank you, Delegate Miller. I don't see any questions.
All right, thank you.
Well
Thank you, Madam
done.
Chair.
That ends the hearing on House Bill 771. And now we have Delegate Hill, House Bill 931, Healthcare Facilities, Nursing Homes, Medical Director Requirements. You're going to present for Delegate Hill. Thank you.
Chair Beidel, Vice Chair Hayes, and members of the committee. Good afternoon. My name is Brendan Murray, Legislative Aide to Delegate Hill, and I am testifying in strong support of HB 931. HB 931 strengthens oversight and the quality of medical care in Maryland nursing homes by requiring physicians designated as a medical director to hold certificate or certification or certified medical director credentials, or an equivalent credential approved by the Department of Health, or to demonstrate active progress towards obtaining such certification. The bill requires each nursing home to publish a medical director's name, promoting transparency and helping families make informed decisions. I support this bill personally and professionally. Both of my parents lived in nursing homes, and I saw firsthand wide variations in medical oversight and quality of care. When my father needed better end-of-life care, I moved him to Maryland so that he could receive appropriate management. That experience showed how critical component accountable medical leadership is to residents' safety, dignity, and outcome. HB 931 balances high standards with practicality by allowing current medical directors a reasonable transition period to become certified and permitted the department to approve equivalent credentials when appropriate. With the amendments reached while working with stakeholders, the bill will not impose an additional cost on the department or facilities. Because of these amendments, the Maryland Department of Health supported the bill and the removal of restrictions that limited the physicians to serving as a designated medical director at no more than 2 nursing homes helped gain the support of Maryland Medical Directors Association and aligned partners. Requiring nursing homes to post medical director information on the website will increase accountability without increasing new financial burdens for facilities or state government. For these reasons, I urge a favorable report on HB 931.
Thank you. Do I have any questions at all for this witness? Seeing no questions, thank you very much. That ends your hearing on House Bill 931. Now we have House Bill 986, Delegate Terraza, Nurse Licensure Educational Requirements Enforcement. Thank you, Delegate.
Hi, good afternoon. Good afternoon, Chair Beidel and Vice Chair Hayes, and esteemed members of the Finance Committee. For the record, I'm Delegate Jen Terraza, and thank you for this opportunity to present House Bill 986, Nurse Licensure Education Requirement Enforcement. So with this bill clarifies and strengthens the role of education verification in the nursing licensure by endorsement process in Maryland. The bill requires applicants for a nursing license in Maryland who already holds a valid license in another state or territory to provide clear evidence that their educational credits are up to state nursing standards. It also ensures the Board of Nursing is able to properly enforce educational requirements. So the problem is that recently national and regional concerns have been raised over diploma mills and falsified transcripts for license applications, especially from out of state. Hearing about this, MDH and the Board of Nurses reached out because they believe there remains some ambiguity in the statute. So this bill does not create additional educational requirements. What it does is require applicants for licensure by endorsement in Maryland to produce evidence if required by the board, that their nursing education credentials meet Maryland statutory and regulatory requirements. And that might include official transcripts. And it adds failure to complete the educational requirements under HOA 8302 as explicit grounds for licensure denial or discipline. These changes will ensure the safety of both patients and nurses. In medical settings, I respectfully urge a favorable report on HB 986.
Delegate, was there a reason for this bill?
Yeah, the concern basically about the diploma mills and the falsified transcripts, and just the Board of Nursing's belief that they need to be able to look closer at some of those and require that information. Yeah, they requested it.
The board requested.
Yeah,
Thank you.
it was at their request.
Thank you for your presentation. Senator Lamb?
Thank you, Madam Chair. So last year, we had sponsored legislation for nurses who had trained abroad and practiced in a different state before coming into Maryland to really streamline their process to get licensed here. These folks oftentimes have a very difficult time being able to obtain like transcripts from when they were undergoing training in their home countries and their schools in their home countries. So is there a way to help ensure that these individuals who have been practicing in the U.S. for so long, to be able to help them find these transcripts in order to help them get licensed? So, you know, to be able to help streamline that process again, because it's been really difficult for them. We're obviously trying to expand the healthcare workforce. And so, you know, basically, are there ways to be able to help these folks in ensuring that they can practice in the U.S. so long as they have, so long that it may be hard for them to find transcripts to still be able to get licensed?
Thank you, Senator, and I think that's a really important question. I don't have all that expertise that the Board of Nursing has. But are you talking about folks who are practicing already here in Maryland, or you're talking about?
No, they're trying to get licensed here in the state of Maryland.
And they've been practicing elsewhere in the United States.
Mm-hmm.
Yeah, I mean, I think my answer would be, and then I could get a further answer from the Board of Nursing. Basically, is this really gives the Board of Nursing the discretion to, they don't have to require transcripts, for example, because I think that's a really valid concern. But they don't have to require those. If they have some reason to question the credentials, they can ask for information, educational information. But I can get further information from you if you'd like.
Okay. Yeah,
This
it's
is
just been really
sponsor,
difficult to get some
Yeah.
of the Board of Nursing to be responsive in getting timely, you know, responses back on applications in reviewing these transcripts. You know, I don't know if it's a staffing issue or what at the Board of
Okay.
Nursing, but it's been, we've heard a lot of concerns about that. So,
Okay, I can ask them to get back to you on that.
Any other questions? Thank you for the bill.
Thanks.
Next, we will have Delegate Austin, Public Health Prohibited Ingredients in Food.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the Senate Finance Committee. I'm here today to present House Bill 1004, Prohibited Ingredients in Food. This bill has had some changes since the last time we were here. As amended, as passed out of the House, what this bill will do is prohibit all ingredients that have been banned by the FDA and give the state enforcement power to make sure that those harmful ingredients are not being sold, manufactured, or used in our food supply, including things like red dye and brominated vegetable oil. We think this is an important legislation, an important piece of legislation to make sure that our state can enforce these policies. And at this juncture, the retailers are on board, and I believe they have sent a letter of support to that effect. I'm happy to answer any questions. This bill passed the House unanimously.
Thank you, Delegate Austin. I don't see any questions. That was easy. Thank you.
Thank you. Have a good day.
So next we have House Bill 1042, Delegate Warman. Health Occupation Structural Racism Training, Funding Sources.
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of Finance Committee. For the record, my name is Karen Gottlieb. I'm Delegate Warman's Chief of Staff, here to present her bill on her behalf. This is a simple bill. It's clarifying what we've already worked on and passed last year. Under Chapter 478 of 2025, we required structural racism training for certain health occupations. As implementation moves forward, HB 41042 makes explicit what was always the intent, that this training be developed and offered at no cost to the state, using external funding sources such as grants like the grant the Maryland Nurses Association received from the American Nurses Association. This bill does not expand the mandate. It does not create a new program. It simply clarifies that the training must be funded through outside resources and not state general funds. If we are going to require something, we have a responsibility to make it clear about how it will be paid for. This bill ensures we can continue advancing meaningful education around healthcare equity while being fiscally responsible and protecting Maryland taxpayers. This cleanup and clarification bill reflects the intent of the General Assembly when we acted last year. I respectfully ask for a favorable report, and I'm happy to ask any questions.
Thank you very much for the bill. I do not see any questions. Thank you. That ends the hearing on House Bill 1042. Next, we'll go to House Bill 1087. Delegate Johnson. I guess I should say Delegate Steve Johnson. Oh, you're going to present for him? Thank you. This is Healthcare Facility Surgical Smoke and Smoke Evacuation System.
Good afternoon, Madam Chair, Vice Chair, members of the Finance Committee. For the record, I'm Eli Brennan, Chief of Staff to Delegate Steve Johnson, here to present House Bill 1087 on his behalf. This is a rare kind of legislation. It will meaningfully improve the lives of essential workers, has zero fiscal impact, and has no written or oral opposition. The bill fills a gap in our laws to require hospitals to use an evacuation system during procedures that create surgical smoke. The Health Committee unanimously supported this bill, and it was passed unanimously by the House of Delegates. Many surgeries involve cauterizing a wound, which creates surgical smoke. It contains many carcinogenic chemicals, bacteria, and sometimes small pieces of a patient's flesh. Surgical smoke is a clear and documented danger to the health of staff and patients in a surgery room, and the average daily impact to a surgical team is the equivalent of inhaling the smoke of 27 to 30 unfiltered cigarettes. On top of that, there have been documented cases of communicable disease transferring from a patient to surgery staff through surgical smoke. Fortunately, the solution is simple and inexpensive, and most surgery rooms are already equipped. This does not require a large new HVAC system, but rather a small tube, usually, that attaches to the tip of a cauterization tool and vents the smoke outside. A 2023 national survey by the Association of Perioperative Registered Nurses found that while 94% of respondents said their facilities had smoke evacuation equipment, only 26% reported consistent use. The solution is literally as simple as flipping a switch most of the time to turn on the vent, and 19 states have already passed legislation requiring surgical smoke to be vented out of the surgery room. The Maryland Hospital Association has submitted an informational letter. They are not opposed to this legislation because Maryland hospitals already have this venting infrastructure installed. Advocates of this bill also met with Johns Hopkins, who are also neutral. Representatives from Johns Hopkins said that, like many hospitals, while they have the venting equipment installed in all their surgery rooms, they don't always require it to be used and often leave it up to the discretion of the surgeon. However, the nurses who breathe the surgical smoke often don't get a say in whether the smoke is vented or not, which is why we should follow other states and require hospitals to use the systems they already have. I respectfully urge a favorable vote for House Bill 1087. I'm happy to answer any questions.
Thank you very much for your testimony. I don't see any questions. Thank you. Delegate Shetty or her representative for House Bill 1490, Family Investment Program, Temporary Cash Assistance.
Chair Beidel and esteemed members of the Senate Finance Committee, for the record, my name is Chloe Shoemaker. I'm here on behalf of Delegate Shetty. Before I begin, Delegate Shetty has actually asked me, Chair Beidel, to take a moment on behalf of her team to thank you for your leadership. You've left an indelible mark on the General Assembly. I was actually here a year ago to testify for her for the child support remittance bill. You had really kind remarks for me after that. It's a little less scary today to be here before you again. Yeah. The bill I'm here for today is House Bill 1490. It's a bill that addresses yet another systematic problem that we have in alleviating poverty for Maryland's most vulnerable families. HB 1490 seeks to standardize what information is required for a custodial guardian who applies for temporary cash assistance. Today, in order to apply for TCA, if you are a custodial parent, you have to surrender the name of the non-custodial parent, and you have to seek a child support order. Seeking a child support order can be difficult or nearly impossible for some custodial parents. Our state law currently allows the department on a case-by-case basis to provide exceptions that exempt a parent from seeking a child support order. While this bill gets into the weeds of what goes into a TC application, it is fundamentally about empowering custodial guardians to make the decisions that are best for their families. DHS as an agency should not decide whether it makes sense for a custodial guardian to seek a child support order. Currently, DHS has regulations in place about how to grant good cause exceptions, but in practice, there are large inconsistencies in how these rules are applied. You can see this in the data. Only 7 good cause exceptions were granted in 2024. Meanwhile, in the month of April alone in 2024, 548 families were denied TCA due to non-cooperation with child support. As it stands today, cooperation with child support is a barrier to financial stability for families facing a crisis. In the submitted written testimony, I'd encourage you to read the statements from custodial mothers who write about how they were fleeing from domestic violence and found today's policies around child support either re-traumatizing or prohibitive for their application. There are also statements from custodial mothers about how difficult the child support order process is when a non-custodial parent is absent from their children's lives. HB 1490 sets a uniform standard about what is a good cause exception. It will also establish policies that require the agency to be more upfront about notifying families applying for TCA that they can request a good cause exception. This bill will not require a huge fiscal lift for DHS. As amended, HB 1490 also incorporates technical feedback from the agency so that they can operationalize the legislative intent of the bill. Cooperation with a child support order should not be a barrier to a family seeking temporary cash assistance. Thank you for your consideration, and I respectfully ask for a favorable report on HB 1490.
Thank you very much for your testimony. We have a question from Senator Washington.
Thank you, Madam Chair. Thank you, and it's really great to see a bill like this, and I'm not surprised that Delegate Shetty, who's very thoughtful, would propose a bill like this to remove that barrier so families can get the cash assistance that they need at a certain time. So I just wanted to say thank you for doing this bill, and please send our regards to Delegate Shetty. I think it's a fantastic bill that's really needed. So thank you.
Absolutely. Yep, I can do that.
Thank you very much. You did a good job again this year. Maybe you get to stay, huh?
Maybe.
Thank you very much for your comments. I think our last bill has some opposition. No, it's not. Yes, it is our last bill. Our last bill has some opposition. It's House Bill 1373, State Board of Dental Examiners, Disciplinary Action and Unannounced Inspections. And we're going to bring up Delegate Kipke and Dan Daugherty from the Maryland State Dental Association, I think. Is Delegate Kipke here or someone representing him? There he is, right on time.
Right. I was running. Good afternoon, Madam Chair, Vice Chair, and members of the esteemed Finance Committee. House Bill 373 is a cleanup bill to a bill that we passed together a couple of years ago, which created a new advanced practice dental assistant. Basically, the bill does two things. It allows the board to discipline an individual who and take complaints about an individual, which without this bill, it's the responsibility of the dentist to look after that. We think it's important that the board have the authority because these individuals could move around to different practices and their history won't travel with them. In confession, that really, I think, was an oversight when we originally passed the bill, and that cleans that up. And then second, it updates some technical terms related to infectious disease control. There are more current CDC guidelines for that, things like sanitizing tools that you put in people's gums, appropriately sanitizing them. There was some opposition to that from just one individual who said that MOSH could do that, but I think we all would agree that the board is responsible for having oversight over that. There is a little bit misleading, there's some words that are misleading in the title about unannounced inspections. This does not change any of that. The board continues to not be allowed to do unannounced inspections. People got concerned about that. They're only allowed to do inspections when a complaint is filed with the board, and then they can go out and do the inspections. This bill doesn't change that at all. And I also want to say that the dentists and the dental hygienists are both in complete agreement on this. With that, I conclude my testimony and be happy to answer any questions.
Let's hear from Mr. Daltrey, and then we'll see if there's questions.
Thank you, Madam Chair, members of the committee. I'm Dan Daugherty here on behalf of the Maryland State Dental Association in support of House Bill 373. Delegate Kipke has outlined what the bill does. I would point you to page 3, beginning with section D through the end of it on page 4. This is basically setting out disciplinary grounds for disciplinary action for these expanded function dental assistants that are currently in place for almost every other licensee under the Dental Practice Act. The detail was not provided in the bill that Delegate Kipke referred to that passed in 2022, and this fills that need to have it comparable. With respect to objections that were raised with the inspections, the unannounced inspection based on a written and signed complaint has been in law forever. If you got a violation of sanitary infection control in a dental office, it's a very severe problem. And if a complaint is received and then you announce you're coming, obviously the dental practice is going to be able to have their act in order when they're inspected. So this is an important part of the law to maintain. The language change is that now the CDC provides prevention guidelines for various settings, and it adds to those CDC guidelines of standard precautions, guidelines for infection control in dental health care settings. That is extremely important, and we would urge you to resist any amendments to change that and give the bill a favorable report as you see it before you. Thank you very much, Madam Chair.
Thank you. Delegate, I'm looking in the bill because I looked at it earlier today and I thought I saw this thing about the unannounced inspections, and I could understand the concern, but I'm not finding it again.
Yeah. Madam Chair, if you would look at the page 2 where you got 4-205A, it's in the first line of the first section of the current law that provides when there's a written and signed complaint, including a referral from the Commissioner of Labor and Industry, they can conduct an unannounced inspection.
Okay, so
they
that was,
cannot do it, though, without complaints coming in those manners.
and that's in current law.
Yes.
Thank you. Okay. Any other questions for the delegate or for Mr. Daughtry? Seeing no questions, we are going to bring up, we have an unfavorable Danielle Varanen. Thank you, Danielle.
Thank you, Madam Chair and members of the committee. My name is Danielle Varanian, and I'm an attorney who represents licensees before the Dental Board, and I'm here today on behalf of Heartland Dental. Members of the committee, make no mistake, this bill does expand the Dental Board's authority to conduct unannounced inspections. If you look at the second page of the bill where it talks about unannounced inspections, it's adding a publication called the Centers for Disease Control and Prevention's Guidelines for Infection Control in Dental Health Care Settings. That is another publication under which the board is asking you to allow it to conduct these unannounced inspections. We have significant concerns about allowing a board more authority when they're not exercising the authority that they already have. I have a client who reported to the board 6 years ago that a dentist that he employed sexually assaulted a dental assistant repeatedly during procedures. This board has yet to take any action. None. No investigation, no subpoena, nothing. I guess it's because it's not a CDC violation. In the last 2 years, this board has summarily suspended 5 dentists. 4 of them were for CDC violations. This seems to be the only issue that they are interested in. Candidly, we have no issue with the board getting statutory authority to exercise disciplinary authority over these expanded function dental assistants. Where we do have an issue, though, is an expansion of their authority to conduct unannounced inspections. And for those reasons, we are requesting an unfavorable report.
Danielle, so the rest of the bill you think is fine. That's a concern that you think that's allowing unannounced.
Yeah, and let me be specific, Madam Chair. Specifically on page 3 to 4 of the bill, where it talks about from line 8 down, that portion of the bill is perfectly fine. What's not okay is what is above that. From line 7 on line 3 up to the beginning.
Thank you. I think we've waited a long time for these expanded duties for dental assistants. Seems like it's been a couple years we've been waiting for this. So thank you for that. Senator Washington?
Thank you. Just can you describe to me what is the main problem with a unannounced visit?
So the problem with an unannounced visit, in particular with this board, is what we have experienced is if you give an inch, they take a mile. So for what's currently in the law, there has to be a written complaint for the board to go in and conduct an unannounced inspection. We don't disagree with that. That's what the law is. However, there have been situations where the board has tried to take that piece of the law and apply it in consent orders where they want to be able to go into, if the dentist owns multiple offices, they want to be able to go into all of the offices that the dentist owns, despite the fact that there's no written complaint. Those are problematic due process concerns. And it's those types of concerns that we're worried about with giving an expansion to that authority.
You're concerned about more oversight, potential more oversight and review of the business's operations?
I'm concerned about inappropriate expansion of their authority when they're not.
Potential harassment.
In some instances, but I'm concerned about expanding authority when they're not using the authority that they already have on very serious issues if it doesn't have anything to do with CDC violations.
Got it. Okay. Thank you very much.
Welcome.
Thank you, Senator. I don't see any other questions. Thank you for your testimony. We have one more virtual. Catherine Wise, Maryland Board of Dental Examiners. Catherine, will you unmute and give us your testimony, please?
Thank you so much. Thank you, Madam Chair Beidel, and esteemed members of the Senate Finance Committee. My name is Catherine Wise, and I'm a member of the Maryland State Board of Dental Examiners, and I'm speaking on behalf of the board. This bill accomplishes 2 things. First, it updates the name of an existing CDC publication, and it adds an important second publication. The board uses these publications when performing infection control inspections, and they are referred to in our reports of CDC violations. Therefore, the statutory language needs to be updated to be current and relevant. Secondly, the board lacks disciplinary action against the newly created EFTA, Expanded Function Dental Assistants. Most dental assistants in Maryland are on-the-job trained. The statutory change would not affect them. The FDA requires specialized training and certification in which they provide direct patient treatment. In fact, they can now perform 4 new functions only previously allowed by dentists and licensed dental hygienists in the past. For example, the general duties FDA can now monitor nitrous oxide sedation. Increased responsibility in healthcare requires professional accountability. All other licensed and certified dental professionals are subject to board disciplinary action, including certified dental radiation technologists who are dental assistants with the additional responsibility of taking dental x-rays. Without this legislation, an unprofessional or incompetent individual could move from office to office, avoiding any repercussion or discipline. Thank you again for this opportunity to testify. I'll be happy to answer any questions you have, and we look forward to receiving a favorable report.
Thank you very much. Do we have any questions for this witness? Thank you very much. Seeing no questions, that ends the hearing on House Bill 373 and ends the hearings for today. Thank you.